Assalamu alaikum wa rahmatullahi wa barakatuh. Hi everybody, welcome to our radiology course for undergraduates. I am Ala Muhammad Rida, lecturer for radio diagnosis. Today we will talk about basics for cardiac imaging. At first, what do you know about X-ray? Simply, this is the X-ray machine, or called X-ray tube, that generate the X-ray in divergent way to penetrate the examined part of the body, whatever abdomen, pelvis, chest, upper limb or lower limb, to penetrate it, then receiving the receptor that generate the image. Again, the X-ray image formation by the X-ray tube, then penetrate the object or examine the part to reach the receptor, then display the image, final image, which is not just or white or black colors, but different X-ray colors or different X-ray densities, ranging from the most black or the most lucent, representing air, and then more bright or more dense, representing fat, more bright representing soft tissue, bright or more dense representing the bone density, and the most bright or most dense representing the metallic shadow or metallic density as metallic foreign body or metallic pacemakers. So there is 5 different X-ray densities. The final image could be displayed on the traditional film for X-ray or the computer monitor recently, which is much more better. The objectives of our lecture: methods of examination of the heart, normal radiological anatomy of the heart, and common pathological diseases of the heart. Let's go to start first with methods of examination of the heart. Many different methods for examination of the heart, starting from plain X-ray, angiography, echocardiography, which is the ultrasound for the heart, CT or computed tomography, magnetic resonance imaging or MRI, radioisotope scanning, or nuclear medicine. Let's start with plain X-ray, which is the most simple and the initial diagnostic modality for assessment of the chest and heart. To assess either normal or abnormal, must be examined into 2 views at least: posterior-anterior view and lateral view. How to differentiate between the image of posterior-anterior view and lateral view? In posterior-anterior view, the heart in the middle of the image, 2 lung fields on both sides. Patient must be centralized. How to know the patient is centralized or not? The trachea is in the center, and the medial end of both clavicles must be in the same distance from the trachea. Lung apex on both sides must be clear and involved in the image. Also, the costophrenic angles on both sides must be involved in the image. This is lateral view. The vertebrae on one side and the sternum on the other side of the image, with heart in the middle. The second method is echocardiography or ultrasound of the heart. This is the picture for echocardiography with 4-chamber view. This is the left atrium, left ventricle with valve in between, right atrium, right ventricle with interatrial septum between both atrium and interventricular septum between both ventricles. The ultrasound or echocardiography of the heart has great advantage called color Doppler study. Color Doppler study has many different colors, ranging from blue color, red color, orange color, and yellow color. These different colors representing the velocity of the blood motion through the heart and its valves. So this method is important for examination of the cardiac chambers and valve motion and its function. Third method is computed tomography or CT. This is the CT machine. Picture for CT machine. It is a recent method for examination of the body, large volume of the body in very short time, The image display on computer monitor and could assess the heart and its great vessels in axial or transverse sections or in coronal cuts or views for examination of the 4 chambers of the heart and its great vessels. The image could be processed in 3D dimensions with rotation in all directions, and the coronary vessels could be examined properly to assess either it is normal or abnormal, or there is areas of calcifications, there is areas of narrowing or occlusion. So it is very important diagnostic modality for the heart. Fourth one is MRI or magnetic resonance imaging. Also, it is a recent modality for examination of the cardiac chambers. This is the MRI machine, and this is picture for MRI image for examination of the cardiac chambers and the morphology of the myocardium and its function. Fifth one is nuclear medicine or radioisotope scanning. This imaging modality is important for the study of the viability of the cardiac tissue by injection in the body of radioisotope material that is specific for the myocardium or the heart. So uptake is specific for the myocardium occur. Must be examined in all views, axial view, sagittal view, and coronal views to assess the uptake of the myocardium. Areas of decreased uptake in the myocardium is important that may be reversible or irreversible. Reversible in cases of myocardial ischemia and irreversible in cases of myocardial infarction. So it is very important to differentiate between ischemia and infarction and the assessment of the cardiac viability. The last one for examination of the heart is angiography, which is important modality, not just diagnostic method but also therapeutic method, under guidance of fluoroscopy apparatus, which is real-time imaging modality. Introduce a catheter, arterial catheter, through the femoral artery, then introduce an advancement of the catheter through the iliac artery, the descending aorta, arch of aorta, and ascending aorta, with injection of contrast material to examine and assessment of the coronary vessels and its branches. So it is image for coronary artery on the left side, and this is image for normal coronary arteries on the right side of the heart with their branches. This is the normal image. So it is important diagnostic modality, but also it is an important modality as a therapeutic way, as detection of areas of narrowing, stenosis, or occlusion could be also treated by balloon dilatation or stent placement under guidance of this angiography. So it is very important method as diagnostic and also therapeutic. The first section is finished of this lecture. Let's go to the second one, which is normal radiological anatomy of the heart. This is diagram for right lung with upper loop, middle loop, and lower loop. 2 fissures in between could be detected. The left one is 2 loops only, upper loop and lower loop, and 1 fissure in between. The mediastinum is the area in between 2 lung fields containing the heart and its pericardial fat, with great vessels arising from the heart. This is X-ray demonstrating that the heart not lying in the mediastinum, neither in longitudinal nor transverse way. It is in oblique axis like this. So the right ventricle is the most anterior structure and the left atrium is the most posterior structure. The right atrium is sharing in the right cardiac border, and the left ventricle and less extent the left atrium and its appendage is sharing in the left cardiac border. Again, the left atrium and its appendage is the most posterior structure, not sharing neither in the right cardiac border. The right atrium sharing the right cardiac border. The left ventricle sharing in the left cardiac border, and the right ventricle, which is the blue one, is the most anterior structure, not sharing neither the right cardiac border nor the left cardiac border. This diagram demonstrates that the cardiac border on the lower aspect on the right side shared by the right atrium, on the left side shared by the left ventricle, and slightly above it the left atrium and its appendage. More slight upward on the left side left pulmonary artery, on the right side right pulmonary artery. More upward the aortic arch with aortopulmonary window in between the aortic arch and left pulmonary artery, and the right side upward contained the superior vena cava. Again, right atrium, left ventricle and left atrial appendage, left pulmonary artery, opposite to it right pulmonary artery, aortic arch and the aortopulmonary window in between, and the superior vena cava on the right side upwards. Again, right atrium, right pulmonary artery, superior vena cava, left ventricle, left atrium and left atrial appendage, left pulmonary artery, aortic arch and aortopulmonary window in between. Again and again, right atrium, right pulmonary artery, superior vena cava, left ventricle, left atrium and left atrial appendage, left pulmonary artery and pulmonary trunk, aortic arch with aortopulmonary window in between. Again, right atrium, right pulmonary artery, superior vena cava, left ventricle, left atrium and its appendage, left pulmonary artery, aortic arch and aortopulmonary window in between. And this is the left hemidiaphragm, right hemidiaphragm, right clavicle, left clavicle and the trachea. The second section is finished also. Let's go to the third one and the most important one for exams. This is the common pathological diseases of the heart. There is many common pathological diseases of the heart as pericardial effusion, cardiomegaly, cardiac chamber enlargement, cardiomyopathy, valve lesions, heart failure, and pulmonary hypertension. Let's start with cardiomegaly. What's meant by cardiomegaly? Cardiomegaly means enlargement of the cardiac shadow, whatever it's real enlargement of the heart or enlargement or filling with fluid surrounding in the pericardial sac. So it's broad term or wide term. What meant by cardiomegaly and how to detect in X-ray? By measuring the cardiothoracic ratio. Cardio means the maximum dimension of the heart. Thoracic means the maximum dimension of the chest from inward to inward, subdivided to each other. Normal cardiothoracic ratio not more than 50%. If it more than 50% means there is cardiomegaly or enlargement of the cardiac shadow like this image. The maximum cardiac shadow dimension subdivided by the maximum chest dimension. There is more than 50%, so there is cardiomegaly. Another image for cardiomegaly, cardiothoracic ratio more than 50%. It is broad term and caused by multiple causes as congenital heart disease, valvular lesions, cardiomyopathy with enlargement of the cardiac chambers, or mass lesions in the heart enlarging it, or fluid surrounding the heart in the pericardial sac as pericardial effusion. So it is non-specific sign or broad term. The second one is pericardial effusion. To detect in X-ray, pericardial effusion must be more than 250 milli to be detected in X-ray. Its sign in X-ray is cardiomegaly also, but there is symmetrical enlargement of the cardiac shadow with giving flask-shaped appearance of the heart, like a flask. So there is cardiomegaly also, flask-shaped heart or symmetrical enlargement of the cardiac shadow. Also there is double density in the periphery of the heart, represented the fluid in the pericardial sac. There is a slight hypodensity surrounding the cardiac shadow, representing the fluid. Is called the double density of the heart. But it has many differential diagnoses also, for as cardiomegaly, dilated cardiomyopathy, multiple valvular lesions. Multiple valvular lesions like this image, not specific, but there is no symmetrical enlargement of the heart. There is cardiomegaly, but no symmetrical enlargement and no flask-shaped heart like in pericardial effusion. The third pathology is cardiomyopathy. Also there is cardiomegaly in cardiomyopathy, but and giving the water bottle configuration, there is a specific sign which is dilatation of the azygos vein, which is here. The azygos vein is venous system on the right side, communicating with the hemiazygos vein on the left side, communicating to each other by multiple venous connections, ending by the azygos arch. If it is dilated and more prominent, so the prominent azygos vein is specific for cardiomyopathy. The fourth pathology is cardiac chamber enlargement. 4 cardiac chamber could be enlarged. The first one is left atrial enlargement. Regarding that the left atrium is the most posterior chamber in the heart, so it may enlarge in any direction. Could be enlarged upward, could be enlarged to the right side, could be enlarged to the left side, and could be enlarged posteriorly. Could be enlarged on the right side, giving double density appearance on the right cardiac border. Could be enlarged on the left side, so enlargement of the left atrial appendage with straightening of the cardiac border. Could be enlarged upward, cause splaying of the carina of the heart, of the trachea, with widening of its angle more than 60%, and could be enlarged posteriorly to compress on the esophagus, which is lying just posterior to it, and examined in the lateral view, known by vertebrae on side and sternum on the other side, and the patient ingests contrast material to make the esophagus more bright or more dense, so compression of the esophagus is detected in this view in barium study. So the signs in X-ray for left atrial enlargement is double density along the right cardiac border, bulging of the left atrial appendage, widening of the angle of the trachea of the carina more than 60 degree, and on barium study the esophagus is displaced posteriorly on lateral view. Another image. To get the full mark in the exam, must comment in 2 steps. The first one is the type of the examination in complete manner, and the sign and the disease of the picture. To comment on this picture, must write it is chest X-ray of the chest and heart, postero-anterior view, not antero-posterior. It is postero-anterior view. The chest is examined in postero-anterior view. Number 2, showing left atrial enlargement in the form of double density on the right cardiac border, enlargement of the left atrial appendage, and displaying of the carina of the trachea more than 60 degree. Another picture to full comment and get the full mark. Postero-anterior view of the chest and heart, showing displaying of the carina of the trachea more than 60 degree, enlargement of the left atrial appendage, double density of the right cardiac border, so the disease is left atrial chamber enlargement. The second chamber enlargement is left ventricular enlargement. Regarding the left ventricle form the cardiac apex, so if it's enlarged, it will get more downward and make the apex displaced downward and more rounded. So to get full comment on this picture, must say that chest x-ray of the chest and heart, postero-anterior view, there is enlargement and downward displacement with rounded appearance of the cardiac apex, left ventricular enlargement. The right atrial enlargement, slightly difficult to be assessed by x-ray, causing increased convexity of the right cardiac border on its lower aspect in postero-anterior view. So to detect in this x-ray, must full comment chest x-ray of the chest and heart, plain x-ray of the chest and heart, postero-anterior view, there is more rounded and bulging of the right cardiac border on its lower aspect, right atrial enlargement, but it is difficult to be assessed. The last chamber is right ventricular enlargement. It is the most anterior chamber, so if it enlarge, it will cause obliteration of the retrosternal space and cause elevation and more rounded appearance of the cardiac apex. So in right ventricular enlargement, again there is rounded and elevated cardiac apex, and in lateral view there is obliteration of the retrosternal space. This picture is plain x-ray of the chest and heart, showing elevated and enlarged rounded appearance of the cardiac apex, represented right ventricular enlargement. And on lateral view, known by that this is the vertebrae and this is the sternum, but it is not plain x-ray. Plain x-ray means no contrast in the image. There is contrast in this image filling the esophagus, so it is not plain x-ray, it is barium study of the esophagus. Lateral view showing obliteration of the retrosternal space by the right ventricular enlargement. Retrosternal space must be clear and lucent like this one, black, but it is here bright due to right ventricular enlargement obliterating this lucent space. The fifth pathology is the valvular lesions. There is many valves to be affected in the heart, but the most important valves is mitral valve and aortic valves are the most commonly affected valves, either congenital or acquired by rheumatic fever, maybe mitral stenosis or mitral regurg. The first one is mitral stenosis. Mitral stenosis means that there is a stenosis of the mitral valve in between the left atrium and left ventricle, so the left atrium is not complete, emptying its blood through the cardiac cycle into the left ventricle, so the blood is congested and dilate the left atrium cycle by cycle. Then it will be enlarged, and then the hemodynamics will regurge through the pulmonary veins, full pulmonary veins into the lung, causing congestion and edema of the capillaries of the lung, then filling fluids inside the alveoli of the lung, causing pulmonary edema, then congestion of the blood and regurge into the pulmonary artery that arise from the right ventricle, causing obstruction of the pathway from the right ventricle to the pulmonary artery, so the right ventricle will be hypertrophy and enlarge in the final stage of the mitral stenosis. Again, the left ventricle not completely filled with blood, left atrium will be enlarged, pulmonary veins will regurge the blood to the lung, which will be congested and edematous, then regurge the blood to the pulmonary artery to the right ventricle, which will be hypertrophic and dilated and enlarged in the final stage of the mitral stenosis. So its sign is left atrial enlargement with normal cardiac size at first, may show mitral valve calcification, pulmonary venous hypertension, pulmonary edema, pulmonary artery hypertension at final stage with enlargement of the right ventricle causing cardiomegaly finally. The most important sign is left atrial enlargement with its appendage due to filling and congestion with blood, causing mitralization or straightening of the left cardiac border, which is a specific sign for the mitral stenosis. Normally, the left cardiac border is slightly concave. It is when it is straight. This called mitralization of the left cardiac border. The second one is mitral regurg. The second one is mitral regurg. The same signs as mitral stenosis, but with much bigger heart cardiomegaly from the start due to volume overload, with enlargement of left atrium and also the left ventricle, which is normal in the mitral stenosis. There is also pulmonary hypertension, venous hypertension, calcification of mitral valve. So to differentiate between mitral regurg and mitral stenosis, there is cardiomegaly from the start with enlargement of both left atrium and both left ventricle. So this image is chest x-ray posterior-anterior view showing mitralization or straightening of the left cardiac border with left ventricular enlargement due to enlargement of the cardiac apex with displacement downwards. So it is picture of mitral regurg. Important note to know that mitral valve lesions occur in conjunction to each other. Mitral stenosis is usually associated with element of mitral regurg, and mitral regurg usually occur with element of mitral stenosis. So the image could be the same in both disease, so-called mitral valve lesion, whatever stenosis or regurg. The third one is aortic stenosis with its subtypes. The stenosis of the aorta could be valvular, which is the most common, or below the valve, subvalvular, or the most rare, which is above the valve or supravalvular. The valvular lesions of the aortic stenosis could be due to degeneration in old age, congenital due to bicuspid valve, not tricuspid, or rheumatic fever. Subvalvular, which may be membranous as congenital, or muscular as idiopathic hypertrophic subaortic stenosis, and the most rare one, which is supravalvular type. The image features is often difficult to be detected in the X-ray or plain X-ray film, as there is no chamber enlargement could be detected, just the enlargement of the ascending aorta due to hemodynamics of the velocity of blood causing enlargement of the aorta post-stenotic dilatation. Also could detect the calcification of the aorta of the patient is old age, more than 40 years old. This image is chest x-ray posterior-anterior view showing enlargement and dilatation of the ascending aorta. Also chest x-ray posterior-anterior view, there is enlargement of the ascending aorta, so it is aortic stenosis. Aortic regurg, the same enlargement of the aorta, but also there is cardiomegaly, so the regurg, whatever aortic or mitral, must be associated with cardiomegaly, but the stenotic lesions, whatever aortic stenosis or mitral stenosis, is usually associated with normal cardiac size, but finally in the final stage may be associated with cardiomegaly, but the regurg lesions associated with cardiomegaly from the start due to volume overload of the blood. The sixth pathology is heart failure. Failure of the heart means that the heart failed to maintain the sufficient oxygenation of the body or sufficient circulation to maintain the adequate oxygenation of the tissues. Maybe right-sided heart failure or left-sided heart failure. Right-sided heart failure usually due to lesions of the lungs as chronic obstructive pulmonary disease. So the imaging features is features of the cause, which is chronic obstructive pulmonary diseases, will be discussed in the chest lecture, and the features of the right-sided heart failure, which is cardiomegaly, enlargement of the cardiac size due to right ventricular enlargement. There is also pulmonary hypertension due to obstructive pathway with the lung. So there is pulmonary arterial enlargement, there is enlargement of the pulmonary artery, and this is what called upper lobe diversion of the pulmonary veins through the post-lung fields, also may be associated with pleural effusion. Left-sided heart failure and the pulmonary edema. This is the terminal bronchiole ending in two respiratory bronchioles that will be divided into multiple alveolar sacs or alveoli connected to each other, surrounded by the capillary beds formed from arterioles and terminal venules. This is the normal lung, and this is the lung of pulmonary edema. The alveoli here is clear and filled with air only, no fluid inside, but in pulmonary edema the alveoli of the lung is filled with fluid. So the pulmonary edema, the lung is wetted or containing fluid in its alveoli. There is the stages for pulmonary edema, that is consequence for left-sided heart failure. There is 3 stages. The first stage is dilatation of the upper lobe vessels. Normally the upper lobe vessels is slightly smaller than the blood vessels in the lower lobe by the effect of the gravity, but if there is congestion and left-sided heart failure with congestion of the pulmonary blood vessels, so it will be dilated and more prominent and will be detected in the upper lobe as dilatation and prominence of its blood vessels, called upper lobe diversion. The second stage is multiple linear opacities in the peripheral lung fields, cause Curlis B line, due to edema of the interstitium of the lung associated with pleural effusion. The third stage is alveolar edema with fluid filling the alveoli, giving bilateral symmetrical perihilar opacities surrounding the heart, giving the pat-wing appearance of the alveolar edema, which is the third stage. Also there is cardiomegaly and enlargement of the cardiac shadow in cases of pulmonary edema. So the first stage is upper lobe diversion. Second stage is interstitial pulmonary edema, represented by Curlis B line bilaterally in post-lung bases. Third stage is alveolar edema or pat-wing appearance, which is perihilar opacities. Let's start to see them. Stage 1, prominence of the upper lobe venous system, called upper lobe diversion. Upper lobe diversion. To full comment, plain X-ray of the chest and heart, postero-anterior view showing prominence of the upper venous blood vessels or upper lobe blood diversion, which is stage 1 of pulmonary edema. Again, chest X-ray, postero-anterior view showing upper lobe venous blood diversion, stage 1 pulmonary edema. Stage 2, which is edema in the interstitium, which is lying in between the alveoli, or the connective tissue in between the alveoli. Plain X-ray, postero-anterior view showing multiple linear peripheral lines in the lung base, Curlis B lines, stage 2 pulmonary edema. Again, chest X-ray, postero-anterior view showing multiple linear peripheral opacities or lines in the lung bases. Stage 2 pulmonary edema, the same one. Stage 3, like a pat wing appearance, chest x-ray, postero-anterior view of the chest and heart, showing bilateral symmetrical perihilar opacities or densities surrounding the heart, associated with cardiomegaly due to increase the cardiothoracic ratio. Stage 3 pulmonary edema. Again, chest x-ray, postero-anterior view of the chest and heart, showing bilateral symmetrical perihilar opacities or densities associated with cardiomegaly. Stage 3 pulmonary edema, pat wing appearance. Again, the same one, chest x-ray, postero-anterior view of the chest and heart, showing bilateral symmetrical perihilar densities or opacities, pat wing appearance associated with cardiomegaly. Stage 3 pulmonary edema. The last pathology is pulmonary hypertension. What means by pulmonary hypertension? It is increased pulmonary arterial pressure more than 25 mm mercury. The imaging features is enlargement of the pulmonary arteries, the central pulmonary arteries, with peripheral attenuation or pruning. So there is enlargement of the central pulmonary arteries with peripheral attenuation or pruning of the pulmonary vasculature. To full comment, chest x-ray, postero-anterior view of the chest and heart, showing prominence of the central or main pulmonary arteries, picture of pulmonary hypertension. Again, chest x-ray, postero-anterior view of the chest and heart, showing prominence of the main pulmonary arteries, central pulmonary arteries with peripheral pruning, picture of pulmonary hypertension. It has differential diagnosis of this picture as bilateral hilar lymph node enlargement cause the same appearance of this picture. We finished the lecture. To revise, the important imaging modality for examination of the heart is plain X-ray. Must be examined into two views, postero-anterior view, not anteroposterior, postero-anterior, and lateral view. Echocardiography with the importance of Doppler for velocity of blood. Computed tomography or CT with 3D reconstruction. MRI for cardiac morphology and function. Nuclear medicine for tissue viability of the myocardium and the differentiation between ischemia and infarction. Angiography, which is diagnostic and also therapeutic way. The heart is lying in oblique axis in the mediastinum. The cardiac shadow, right atrium, right pulmonary artery, superior vena cava, left ventricle, left atrium and left atrial appendage, left pulmonary artery, aortic arch with aortopulmonary window in between. To revise the pathological diseases, cardiomegaly means increase the cardiothoracic ratio more than 50%. Many different causes can cause the same sign. Pericardial effusion causing cardiomegaly with flask-shaped appearance of the heart and the double density of the periphery. The differential diagnosis is multiple valvular lesion but asymmetrical enlargement of the heart. Cardiomyopathy causing cardiomegaly with prominence of the azygos arch. Cardiac chamber enlargement, the left atrial enlargement sign is double density of the right side of the heart, prominence and bulging of the left atrial appendage, splaying of the carina more than 60 degrees, and in barium study in the lateral view there is compression and attenuation of the esophagus. The left ventricular enlargement goes downward and rounded appearance of the cardiac apex. The right atrial enlargement causes bulging and rounded appearance of the right cardiac border from the lower aspect. Right ventricular enlargement causes elevated and rounded appearance of the cardiac apex with obliteration of the retrosternal space in the lateral view. Valvular lesions, the most important is mitral stenosis with left atrial enlargement, pulmonary venous hypertension, pulmonary edema, pulmonary arterial hypertension, and enlargement of the right ventricle. Finally, the important sign is mitralization or straightening of the left cardiac border. Mitral regurg the same but with cardiomegaly. Aortic stenosis, 3 types, just enlargement of the ascending aorta. Aortic regurg associated with cardiomegaly also. Heart failure may be right-sided or left-sided with 3 stages of pulmonary edema. Stage 1, upper lobe diversion. Stage 2, careless B lines. Stage 3, pet wing appearance, perihilar opacities or densities. And the last one is pulmonary hypertension with enlargement and the prominence of the central pulmonary arteries with pruning and attenuation of the peripheral pulmonary vasculature. We finished the lecture. Hope you enjoy it and it was fruitful and interesting. See you again, inshallah. Thank you very much for your listening.